representatives from a company?
I'm clinical.
Okay. Anybody else on? I see a 570, and I was wondering who I was talking to.
This is Carol.
All right, so I'm going to go through a couple of contraindications. Have you used a lot of negative pressure in the past?
Yes, I've used it, yes. Mm-hmm.
Okay, so we'll just sort of fly through this. I always tell people no eschar present, and I also on the slough level, I of course have always preferred that it be debrided out, but maybe if you had like 5 or 10% of slough, you could put negative pressure on, you could still get that autolytic debridement. Of course, you don't ever want to use it over a pacemaker where a malignancy was actually present. If it had been in any way surgically taken out, we just don't want to put anything back there. Untreated osteo, of course. Any exposed blood vessels, nerves, any organs, anything like that. What I always say is just use really, really extreme caution with any bleeding issues. Anticoagulants, a lot of people are on Coumadin, heparin, and they still go on negative pressure. But if there's any type of bleeding warnings or anything like that, let me know. Well, don't let me know, but definitely sort of walk away from it. If the person had a Schopp's debridement, I know sometimes that the doctors like to put it on. But I always sort of say I still feel like almost like a 24-hour. Of course, you can never go against doctor's orders, but sometimes I have in the past called the doctors and just asked. Okay. Unexplored fistulas. Once you know where the fistula is going, then the physician can make a decision. And always read all the book. Any negative pressure, just go through the book. Make sure you really know what you're doing with the negative pressure and how to properly use the machine. You'd be surprised some of the calls I get. People really, you may know it very well, but some people really are unfamiliar with wound care. So different wounds that are sort of appropriate. And of course, this is not, every situation, but these are just some wounds that they've been used on in the past. Of course, acute wounds and surgical wounds, you see them all the time. The chronic wound, sort of have to figure out what made the wound chronic. And then a lot of times the negative pressure has been known to stimulate and every once in a while sort of kickstart that wound again. And arterial, most of the time you'll see that it has to be protected. You have to put something in there to protect if there's a tendon exposed or anything. Times a good opportunity is to put in something like Aquaphor. And then we have diabetic ulcers, pressure ulcers, stage 2 through 4. And then of course you'll also see them used with grafts as well. And sometimes you'll see them run at a lower setting if it's an actual graft. Hi Patricia, I saw that you joined in. Okay. I'm gonna just unmute. Hi Patricia, I did see that you joined in. Patricia, can you hear me? Okay, so anyway, we'll just keep going, and maybe, Patricia, maybe you can write me a note or something to let me know that you can hear me. Quick clinical note, I'm going to educate you on the basics, contraindications, techniques, and things like that. And then this is my email here, so if by any chance you want any further information from me, you can email me here. And there are other opportunities to do clinical educations as well. Okay, so here's the kit, okay, and like I said, this is the UNI black foam dressing kit, and it comes completely sterile. So when you get everything, pretty much everything's inside that you're going to need. You'll need a few extra things, but this is what comes inside the kit. You have your 1, 2, 3 drape that is very easy to use. You'll have your black foam, and it will depend, small, medium, and large, depending on what your need is at that time. Here is your dome, tubing, and this is your, it's just an adapter. So this comes off, and it's basically like a lower lock system. Items needed before starting: grab some saline, some skin prep if that's your protocol, ruler to measure it, pair of scissors, really good scissors, are definitely going to help with cutting the foam. And then, of course, I always grab a flashlight and some extra 4x4 so that I can dry the wound. You want to assess the wound, and I think this is the biggest thing that I always say in anything. You want to assess, this is where you really want to know your warnings and contraindications. Is it appropriate? So we're going to be doing this wound today, and I have gotten a few calls in the past about, well, why would you put the dome on this area, because it should be bridged, but this is not a bridging video. So what I do is I do put it here just for the sake of, I don't have a lot of opportunities on the wound, but I do have other ones that would actually create bridges between. And as you can see, technically this would not be appropriate because here we have our black eschar, so we definitely would not want to put opsite all over that. Here we have some potential of osteo. Here's a whole bunch of slough, but again, I'm using this as a sample, so just so you know. I'm just going to irrigate the wound very well, and it is important to irrigate. I know some nurses will just like pour a little in, but especially when using the black foam, there's the potential of having small particles. And if the small particles get in there, sometimes they sort of get mistaken as necrotic tissue, things like that. So just know that. Here we're measuring the wound. And you're probably going to want to document that again per your facility protocol, most likely every week. So here we skin prep around the edges of the wound, just as a barrier. There is a non-sting version, takes a little bit longer to dry, but I think the patients appreciate it. You may also decide to protect this area further with either some opsite, some thin duoderm, whatever your facility protocol is for window painting. Okay, so this is not, and I put this in here just so you have it. The oil emulsion does not come in a kit. This is a contact layer, but because I do have a bone, I want to make sure I protect that area, and this is one thing that you can use. So I'm using that to protect the exposed bone. It also helps to utilize it to prevent any type of sticking to the wound bed. There's a few different oil emulsions out there, of course. I think this one is like an adaptic or something. You just don't want to use one with that thick oil base. I think if you've ever used them, there's some that have very thick oil. That would not be appropriate to use. And of course, you need a doctor's order to be able to put this in. And the only other thing I'm going to add about the oil emulsion is just be careful, because boy, it does sort of disappear on the wound bed and blend in. So you just want to make sure whatever goes in comes back out. So this is the white foam, the hydrophilic foam. The difference, the black foam is hydrophobic. It does not like water, so that's why everything passes through very well. It also doesn't contain, it doesn't like get sopped up. The white foam actually likes moisture. It's a great thing for undermining, tunneling, maybe protecting an area that is more sensitive. If you do have a problem with a wound, really sticking or something like that, maybe putting this down, and again, need a physician's order to add this. But this foam has sort of a higher tensile strength, so it makes it a really good option for, protecting those areas, the undermining and the tunnel that we can't really see inside. You just always, and I think I have a picture of it. I will, okay. I'm going to cut this, and the reason I'm doing this is on my wound I have some undermining. So I want to cut the white foam away from my wound bed so I have no fibers, but I will say the white foam is great. You don't get many fibers at all. Now I'm going to place it into the wound bed. gently. And as you can see, my undermining goes somewhere up like that. So this is in. But if you can see, that's quite a long tail I've left, and I like really big tails on things because I want to make sure that in no way could this get lost. Then I'm going to take my black foam. I'm going to get a fantastic pair of scissors, because sometimes what I'm going to want to do is I might have to fillet it like a fish and make the depth more shallow. For example, even on this wound, I have to sort of come down a little on one side because there's just too much foam. So I cut my black foam to fit my wound bed, again away from my wound bed so no fragments go in. And then place it in, and you'll see here, just as an exaggerated example, I made sure that it came up higher, because as it compresses down, I want it to compress almost level. I don't want it to be like a hollowed out wound. When you work with this wound butt, it really compresses down really well, so you might see a little bit hollows later. So now I have my white foam in, I have my black foam in. Everybody does things different. Some people cut their hole after they place their drape. What I like to do is determine where I want my hole to be on my drape, figure how much I can cut away, like I might be able to cut all that off so I don't have that much on my, my margins. But I definitely want to be out here so I get a nice good seal. But this helps me determine that I can cut the hole right here. What I do is I actually cut first. So I fold it in half, I cut a little nickel size hole out, and that way it prevents any ripping. My hole is nice and round. It's not a slit that sometimes you get when you lift the drape and you go to do it, and then later you end up with a nice little leak. And then I want to make sure that my hole needs to line over the center of my foam for best results. Love this drape. This drape was created definitely with the nurse in mind. For any of you guys that are listening, and I think that somebody else joined as well, anybody listening, the nightmares of drape with gloves, this is not a nightmare drape. This is fantastic. I'm able to hold here, peel off drape number 1, all the backing. I can flip it over, position it so my hole's in the middle, and then very lightly sort of go around and just make sure that I'm adhered down. I don't press on my black foam, I just sort of go around. Every once in a while I'll put like a little tiny V or something where maybe I have to follow the curves, since it's important to do that. So here again, I'm just doing everything very gently. I'm sealing my edges. I don't want to pull on the drape. A lot of times that's another thing, keeping that drape too taut, not a good thing, because then as soon as the patient gets up and moves, you end up having buckles and it starts to come off out of the skin. And that's not great. That's that it really needs to follow those body curves so that doesn't happen. Now I'm just removing drape number 2, and as you can see, I lift up the side and I pull from the bottom. So if you're not used to that type of a drape, that's where that is. That little flap is underneath. And then I just press that down gently and neatly and follow my body contours, and then I'm able to pull off that blue tab at the end. Okay, so this is number 3. What you can do is you're going to hold this blue tab here, and then as you can see, there's a little serrated edge. Just grab that serrated edge and you pull up number 3. Nothing sticks to your hands. There's no issues at all and no struggling with the removal of the top drape. And then you can pull off your blue tabs. I was a little too quick on that, but they pull off very nicely. This is what you're left with, and as you can see, if the patient was to get up, this wouldn't buckle because I just made this little V here to make it a little bit easier. All right, here's a little video, and this is how you do the new domes.
Okay, so here's our new dome, which is extremely user-friendly. As you can tell, it has a peel one side, and then it has peel two, and you can see the arrows are going this way, and then a peel two on this side with the arrows going this way, and then just a number 3 that's just a hold and tear. So what we're going to be doing is we're going to be lining up our dome hole with the hole that we've cut in a transparent drape. And we're going to do that by just easily peeling number 1 off. So we have number 1, and as you can see, all we're going to do is we're going to decide where our tubing is going to come out, and we're going to make sure our holes are completely lined up so that we don't end up having any blockages. And we're very gently just going to go around the edges. Then we're going to grab our number 2, and as you can tell, the arrows are coming this way, so it's just lift and remove on that side, and lift and remove on that side, easy as 1, 2, 3. And these are our number 3, that all this is a tear. So we take our number 3s off, and now we're just going to take our tubing, we're going to connect it to our canister and our pump, and we're going to turn it on. We're going to check that the doctor's orders, what he actually ordered for millimeters of mercury, just to double check. I'm going to turn it on, and you're going to be good to go.
Where we're at. And very, very good meaning nurses, because what we want is once this is done, and it's taken us a while, God knows that sometimes we want to keep it on. So people will put transparent drape again over this and cover this whole area. And that actually causes like almost like an airlock within it. It needs a transmission of oxygen to some degree. So therefore, it ends up alarming later on. It might take a little while, but you'll end up alarming. So we don't want to cover this dome pad. We might have to put some extra on the sides and things like that just to extra protect it. But once that's done, we connect it to the canister and we compress the way the picture was taken, but it's all compressed. And then here you can do all different things. I just happen to have a little piece of extra white foam, so I cut a little tunnel out because this patient happened to have very, very bad skin integrity, and we're worried about the tubing, so there was an idea. You can do all different things. I then created like a little chevron or something and taped the tubing down, because that's important, because you don't want this tubing pulling up and then pulling this part up, because although it won't completely break seal, it will cause alarms to go off and drive nurses crazy, and I don't want that to happen for you. So this is just one way. Another way is this is an actual chevron, just putting the chevron, putting it down and making sure that everything is completely sealed, firm up, so that again your nurses are not going to be sitting there and saying, oh my God. So this was a very simple basic. Of course, there's also bridging. There is bridging to offload. There's bridging two wounds together. There's some reasons you would do a Y port versus a bridge, things like that. So they come up in other, probably next month. I'll probably do a bridging video next month. But I do want to thank you for joining me today. And what I would love is, as people do, I put up my Holly WCC at yahoo.com. And what my hope is that people realize these are, these are just given for the ability of helping out people. So please look at my other products. Please call me if you have any other education opportunities that you'd like me to take care of. And please email me with where you're from. I know I have Taylor, Patricia, Carol on today. So please email me with, your thoughts and also where you're from and things like that, so that as I get things, I can email you opportunities and things like that. But thank you very much for today. I hope you enjoyed the webinar. All right, bye-bye. Does anybody have any questions? Forgot to ask that.
Holly, could you just give me that email address again?
Sure. In fact, I don't know why that screen doesn't come up.
No.
Oh, all right. It's Holly, so it's HOLLY WCC at yahoo.com. So it's Holly Wound Care Certified initials at yahoo.com. And I'll also give you my number, because I think I have all nurses on. My number is 401-808-9301. It's wonderful if people let me know where they're from, if they're from long-term care, if they're, work with a certain product. It's great to know what, and sort of make up a nice little collaboration of nurses. So feel free.
Thank you.
You're very welcome. I hope everybody enjoyed it, and I'll see you at my next one.
Thank you.
You're welcome. Have a great day.